Good evening, community. My name is Rachel Wiley. I'm the Bay Area Executive Director for Pure Health Exchange. It is really an honor to have you with us this evening. We've been waiting and looking forward to this conversation for quite some time. And so again, we appreciate your time and your willingness to join us for it. First and foremost, as we always do in our events, gratitude is in order. First piece of gratitude I'd like to give is to Stanford Children's Health. They are a sponsor this evening. We appreciate them. They are the reason this event is happening alongside some other folks who I'll mention in a second. In particular, we'd like to thank Joey Vaughn and his team for their endorsement of the importance of community conversation around health equity. It's a big deal. We appreciate you. Next, we'd like to thank our Bay Next Council. That's Danielle, Elizabeth, Lila, Heather, Katie, Catherine, Remy. They are, of course, someone is calling me. It's my mother, excuse me. They are a Bay Area Next Council. They are young adult leaders, and they are the folks that have conceptualized this speaker series of this is the second of two. And so we appreciate them for their ingenuity, but also for their leadership. As always, our Bay Board of Advisors, that's Addie, Amy, Creighton, Dana, Izzy, Jill, Jimmy, Laura, Melissa, Molly, Napoon. As you can see, our team runs very deep, but we like to name people and thank them for all that they do to make sure that we can do our work at PHE. Last, but certainly not least, those of you who have been at events for PHE Bay Area before know that often my face is in the front, but the person who really makes this happen and makes sure that nothing falls down is Sasha Rosemond, who is our Bay Development Manager, and also the person who, as always, made sure everything was running smoothly for this event tonight. So we give her a special thanks. She also is the person who will be running our question and answer section with Dr. Pham later on in the program. So make sure that you know her. She's an important person to know. Our program tonight, community, is as follows. We'll do a welcome. Actually, it's already happened. It came and it went. Welcome. Thank you for being here. We will have our discussion with our esteemed guest number one. That's Dr. Christina Pham of UCSF School of Medicine. She will be in conversation with Katie Leyendecker, who is one of our next council leaders. That will be about 25 minutes of our time. Then we'll shift over into a Q&A session, as we said before, with Dr. Pham and with Sasha Rosemond. That'll be about 10 minutes. Sasha will let you know how you go about that. I think that we may do both live questions and just chat questions. If I'm wrong and I lied, she will tell me, listen to her, not to me. Then we will end our program by talking with our second esteemed guest, that's Sophie Jeanette, who is one of our health educators. And I have the pleasure of interviewing her about her experience as a health educator in this moment where everything is virtual at PHE. We'll close out, we'll bid you farewell. We'll thank you once again for joining us. And with that, I'm not going to pass it. I'm actually going to keep talking, but what I'd like to make sure you understand, community, is who we are and what we are doing at Pure Health Exchange. And whenever we do that, I like to focus folks on the name, because the name actually gives you all the clues and all the insight that you need, but I'm happy to break it down for you. So the health, let's start with health. Pure Health Exchange, health is where we focus first. So at Pure Health Exchange, we're focused on empowering young people to make informed decisions about their sexual health, their mental health, and how they use substances through a skills-based health curriculum that we deliver in high schools. We at Pure Health Exchange believe that access to quality health education should be a right. And yet we also know that many students are in schools that do not have the resources to provide and prioritize health education. In this era of COVID, we want to make sure that we say that mental health education is in a special gap. To this end, we have developed an app that will launch next month and will position us to reach significantly more students than we ever have before, which is really exciting. And our goal by 2024 is to reach about 200,000 students annually. That's the health piece. Peer piece is next. We galvanize college-age health educators, who we often call volunteers, to impart health knowledge to young people in partnership with schools that serve primarily students from families with low household income. And then the last part, the exchange part, is actually my favorite. I'm very partial to this piece. So our health educators are not there to tell students what choices they should be making in this life. They're there to connect with them authentically, and by virtue of those relationships that they build, really intentionally support students to engage around sensitive topics and to develop the agency to feel convicted in their ability to make the best decisions for themselves. So that's what we do. Why are we here tonight? So these conversations that we're having are designed to create space where the PHE team can learn alongside our larger community. Our involvement in health equity work, I want to be really, really clear with you all, does not render us experts in any capacity. We need to always be learning. We need to always be growing. And to that end, we constantly are engaging experts to help us grow our knowledge day by day by day. It remains our responsibility to continually expand our awareness of where health inequity creates division and chaos, and to recommit ourselves to advocacy time and time again. So in that spirit, my promise to you is that this will not be your average COVID-19 conversation. We have the pleasure of engaging with Dr. Pham about really three kind of buckets: where health inequity has shown up during the COVID-19 era, what lessons we should learn from what has transpired, and then lastly, what must change to embrace greater inclusion in the future. So tonight we're here, I think in summary of sorts, to talk about what's next and not just what happened, which feels very timely. I want to ask this community to hold something with me for a moment, please, just for a moment. So as we all know, yesterday our system delivered accountability for a crime that was committed, the public execution of George Floyd. Accountability is the word that I want to focus on. When we talk about justice, from where I sit, justice is something that's actually quite different. Justice is defined as just behavior and just treatment. Justice would mean that George Floyd would still be walking among us today. I also want to share with you all that today I had a moment where I sat outside for about an hour and I just looked at the sky. It was my favorite part of the day. And it was my favorite part of the day because I became really aware of what it feels like to be alive, to be fully alive as a Black woman. And sometimes that can feel more like a privilege than it feels like a right. I'm 33, and the weight of that inequity is very heavy a lot of times for me. And my thoughts always then go to what it's like to be 15, which is the age of the students that we serve. The vast majority of those students that we serve self-identify, as Black, brown, or as people of color. To be such in this country means to have an acute understanding of systems and the way in which they have not been engineered for our success and for our protection all the time. And so justice as it relates to health equity looks like access and looks like agency, no matter one's zip code and no matter one's racial identity. Some of the systems that we collectively uphold are the enemy of equity, and we have to know that. So what's next from where I sit is that we hold each other accountable to continually expanding our knowledge about where inequity exists so that we can provide a counterbalance to it, yes, but also so that we can understand how to eradicate it. So lastly, before I pass it, I see conversations like this as really critical starting points within community, and I appreciate you from the bottom of my heart for meeting us at this place, ready to learn, and then hopefully ready to share after taking in some really valuable knowledge. So with that, I'm passing to Dr. Pham and to Katie Leyendecker. So grateful to both of you for hosting this conversation for us. We appreciate you, and I'm gonna step back. I'm ready to listen and learn. Thank you.
Thank you, Rachel, and thank you for that amazing intro. And your words were beautiful, so thank you so much for starting us in that space. And I think, unfortunately, COVID is such a space where health inequity has really driven a lot of what we've seen and what we will continue to see. So I'm very excited to be here all with you for this conversation and to have Dr. Christina Pham with us today. A little background on Dr. Pham before we jump into our questions. She's currently an internist at UCSF, focusing on primary care. She had a unique entry into being a doctor. She started her undergraduate degree in human biology at Stanford University, but really focused on health policy. And her focus was on Vietnamese population's access to healthcare. She went on to study in the UK at Oxford to look at the National Health Service system, which is, for those of you who don't know, a centralized form of healthcare as opposed to what we have here in the United States that is government funded. She eventually went to attend medical school at UCSF, and she chose to do her residency at Harvard with the last public hospital in Massachusetts, where she cared for a diverse and underserved community whose patients were frequently required medical interpreters. So I cannot think of anyone better to have this conversation about health equity with us. And so thank you, first of all, Dr. Pham, for being here. And to kick us off, can you please frame where we are now from a vaccine standpoint in COVID?
Absolutely. Thank you so much, Katie. I first wanted to send a big thank you to Margot Phillips for connecting me to this wonderful, wonderful organization. It's an honor and a pleasure to be with you here. And, you know, you are doing such important work. And so I am really excited for our conversation. I find that it is useful to take a moment to recognize that all of us here are a part of the largest vaccination campaign in human history right now. Right, we are seeing a lot of inequities, but I mean, this is historic. And so, where are we overall from a vaccine standpoint? There are first, you know, the big buckets of vaccines. They're the two famed mRNA vaccines, whose basic mechanism is to deliver a snippet of mRNA that codes for the spike protein into your body, protected in a little lipid envelope. And then from there, teach your body to recognize the proteins, and then to create memory for them for future infections. The second big bucket doesn't have mRNA. Instead, it has the protein, basically a SARS-CoV lookalike that does the same thing, where it's put into a viral vector, usually an adenovirus vector. The adenovirus is a virus that usually causes the common cold. And so it's put into the virus, put into your body, and from there, we go through the same process of recognition and memory creating. There is actually a third bucket of vaccine, one that I don't know if you've heard of a company called Novavax. This vaccine is a little bit different and combines the mechanism of kind of those first two buckets. This one has a genetic code mechanism that is delivered into your body through a virus. And so there is DNA that codes for the spike protein, but it's put into a virus called the baculovirus. They inject that virus, interestingly, into moth cells, and they use moth cells as kind of a production site. So these moth cells will produce a ton of spike protein, and then they'll take that spike protein, make it into a nanoparticle, and it's that nanoparticle that is injected into you. And so the first bucket, there is mRNA that's put into lipids, that's put into you. The second type of vaccine is protein put into a virus, put into you. The third is just protein made into nanoparticles, and that is put into you. The Novavax is currently not yet approved, but they're hoping to get approval sometime later this year. In terms of, you know, general thinking about vaccines, some other tidbits that might be of interest. So the ages that these vaccines are approved for, the Moderna is approved for 18 and above, and studies are underway, hopefully for 12 and above, to be approved in a couple of months. I'm crossing my fingers. The Pfizer is ages 16 and older, and the Johnson & Johnson Janssen vaccine, which is one of the adenovirus vaccines, is for ages 18 and up. I find that the other thing that we should really keep in the back of our minds, especially when it comes to discussions of vaccine equality or inequality, is how you store these vaccines and how long they can last at what temperatures. So the Pfizer vaccine is the most kind of unstable or finicky. That at 25 degrees Fahrenheit. So 25 degrees Fahrenheit is kind of ski weather, right? You go up to Tahoe, it's a brisk day. It can only last 5 days at that temperature. But at minus 94 degrees Fahrenheit, it'll last 6 months. That's important because that has a lot of logistical implications. It takes a lot of technology and cost to be able to transport and to store the Pfizer vaccine. The Moderna vaccine is a little more stable. It can last a month at 25 degrees Fahrenheit. The viral vector protein mechanism vaccines, they can last 3 months in 36 to 46 degrees Fahrenheit, which is, significantly warmer than the 25 that we were previously talking about. And it will last for 2 years at negative 20 degrees Fahrenheit. So that becomes, quite important. I had not mentioned the China and the Russia vaccines. They have chosen to use for their own distribution vaccines that were produced in their own countries. Interestingly, even though the efficacy hasn't been shown to be as good as the vaccines that I just mentioned. Let's see, globally, when we talk about cases, it's very sobering. Throughout the world, we've seen 141 million cases, 3 million deaths. If we look at the US, we are at approximately 32 million cases, 550,000 deaths. You compare that with China's experience. They've had 90,000. Okay, so we had 32 million, 550,000 deaths. China has had 90,000 cases, 4.6 thousand deaths. I'm going to compare that now to San Francisco. In San Francisco, which is where a lot of us are, 36,000 cases, 529 deaths so far. Currently in the US, fortunately, the case rate for many locations is decreasing, but unfortunately in places like Michigan and Florida, they're going through a surge. Internationally, Brazil and India are currently in the hotspots. When we look at vaccines, the vaccine picture globally, if we look at worldwide doses, okay, 925 million doses administered, which covers about 6% of the global population, being vaccinated at 16 million doses a day. And so that, just think back to, that thing that I said in the beginning. This is historic, 16 million doses a day. I just can't even get my head around it. In the US, we are at 213 million doses, which is interestingly about 35% of our population with at least one dose. And so we are vaccinating at a rate of about 3 million doses per day. Really, really good news is since we had focused on the elderly population in the US, when you look at 75-year-olds and above, about 70% of them are fully vaccinated, which is, I think a measure of great success for us. Let's see, and then as we kind of get more local in California, we've had 27 million doses, and that puts us at about a quarter of our entire kind of state population fully vaccinated. And then I want to kind of end this kind of overview with looking at San Francisco. 37% of San Francisco residents are fully vaccinated, which is amazing because we are looking to achieve 75% for herd immunity.
Yeah, it's definitely been encouraging to see those numbers, to your point on how China or New Zealand, Australia have coped with COVID versus how we have. It definitely seems like the US strategy at this point is just try to get everyone vaccinated because people are not stopping what they're doing, which obviously brings in a lot of health equity questions when it comes to who's getting access to the vaccines. I wonder if you could provide some light on what you've seen in terms of access to vaccines, specifically in California and populations. We heard things about, community access codes at the beginning. There's been a lot around trying the California government trying to target health inequity, but not doing a great job. So I'd love to hear a bit about, where we currently stand.
Right. So I think that first of all, we do need to take a moment to recognize how much of this inequality has affected the Black and Brown communities. There's no getting around that. I think one of the biggest drivers of inequity is financial power, right? That is being played out on the international level, the national level, the local level. Probably one of the best illustrators of this. And so when you look at internationally, the US and the UK are doing very well in terms of how fast we are vaccinating our populations. It turns out this is not because we've been so great about, how we're rolling it out, how we're distributing the vaccines. Turns out it has to do with the fact that our two countries had enough financial power to purchase vaccines before they were approved to be used in our countries, right? So before we got the go-ahead from the FDA to say, yes, you can use these vaccines on your people, on your citizens, we had already purchased them and they were ready to go, such that when the FDA gave the word, the trucks could roll out and distribution could start. The EU had to negotiate. That delayed their distribution by a matter of weeks. And many countries just don't have the power to buy something before their own countries give the go-ahead. And so, financial power is a huge driver. With financial power comes a seat at the table, right?
Definitely.
And so,
oh, sorry, I did not.
go ahead.
I would say definitely. I think we've seen that too in terms of just who in the United States has gotten vaccinated. I know when we chatted before, we talked about the biggest drivers of who got vaccinated was access to a flexible schedule and access to technology. And that was really driving who in the United States was getting vaccinated. Obviously, those are problems that are pretty hard to fix with targeted programs like the codes that were being used, et cetera. So do you think the best way to reduce health equity is just to try to get as many people vaccinated as quickly as possible? I noticed there was a question in the chat about the UK approach to doing just one shot, getting everyone's one shot and not bothering it with the second. Do you think that's potentially a way, or maybe one of our takeaways from COVID that could help us have a more equitable result next time this happens?
Oh, that's so hard. There are so many layers to that. And so, if our goal is to get as many people vaccinated as possible, I do think that the UK's strategy that was actually really kind of supported by Dr. Wachter, who is kind of a big name in COVID here at UCSF. He was a big supporter of, just get the first dose in. It's probably, 70-80% effective. And then the second go around, we can try to get the second dose into people. I think Canada and the UK have done that to, very good success. I think that is definitely what you should do if you just want the greatest number of people vaccinated the fastest. I'm not sure if that addresses all the equity issues, but yeah, that certainly can, it can give us more access quicker. I think that there are, other than kind of the financial barriers we talked about, I agree that technology was huge. To be able to consume the information that was being distributed by, all the avenues, first of all, you had to basically speak English. You had to have access to the internet. You had to essentially have access to a smartphone so that you can stalk these sites to make appointments for vaccinations. You had to be able to have flexibility in your schedule to be able to take time off to go and get the vaccines, or now with teenagers being able to get the vaccine, many of these places require parental presence as well for these teenagers to get vaccines. And so now you have to go and, take off so that your kid can get a vaccine. And so you have to have so much privilege to be able to do these things, to pay for transportation to get to these mass vaccination sites. And so, I think that probably one of the most successful threads that I've seen in efforts to kind of bridge these inequalities all throughout the US is working with specific communities within their cultural norms, within their usual lines of communication to really get to the patients.
Definitely. I think we've seen a couple community programs that I've heard of, at least, that have been pretty successful, which has been heartening to see. I know we also talked about, in terms of what we all can do to improve health equity and try to make it at least a little marginally better. And we ended up talking a lot about access to high quality information as something we can all work on. Obviously, PHE works to be a source of quality information for teenagers and college students. But any thoughts you have on that would be great to hear.
Yeah, I do think that the quality of information and the ease at which people pick up bad information, that has been a huge problem, especially in the last couple of years. I think as young people, we have a very, very important role to play in evaluating our sources, and then to be able to bring those good sources back to the people that may not have access to that information. I think elderly people, those who don't have ready access to social media, to the internet, those are the people who are really counting on our young people to bring them high quality information. I think that a lot of the elderly folks who have had vaccine hesitancy they've gotten information from their family members, from their younger friends, spreading information that isn't accurate. And so I think, especially for young people, especially for those who are working with this organization, I think that's a very important role for us to play.
Definitely. And going forward, and then we'll turn it over to the Q&A. I know we have a couple more questions in the chat that Sasha will be able to do. But last question from me is, anything else we can be doing? Obviously, getting vaccinated is important, being part of conversations like these, but are there other things that we can be doing more broadly? I guess maybe talking to our family members, but just to really drive home quality information that the people are getting on COVID and the vaccines available.
Yeah, I think getting the right information to people's ears is very important. But also, we can young people can act as healthcare navigators. So we all know people who have not been able to get access to the vaccines. Be the agent, be the person to access the appointments online for them, make appointments for them, help bring them to the locations of these mass vaccinations, be there with them as they sit and wait. We can be those agents that can be that bridge between the institutions and the healthcare delivery and the people who are not being as well served.
Yeah. And looking to our future with COVID, well, I know Asia has a model because they experienced SARS, and so maybe we're headed that way. But what do you think our future looks like in a couple of years from now?
I think our future looks really, really wonderful. So, one, Asia has been through this before. That's why they were able to keep their numbers as low. They knew that this is a real thing. They didn't have to go through the pain of deciding whether or not, masks were going to work, whether or not they needed to be out of school, whether or not social distancing worked. And so, I think that we've learned some really, really important lessons, and we've really taught ourselves what good public health hygiene is. We totally decimated the flu season this year. And so, I think we've proven to ourselves how amazing research dollars have kind of pushed forward our vaccine effort, and how fast they were able to put things together to save so many lives. That was nothing short of, miraculous. And, I do think that going forward, coronavirus will likely be with us, if not forever, then probably for a long time, because it's the coronavirus, because it mutates so quickly. If I had to put my money down right now, I would guess that this boosters for the coronavirus will be kind of rolled into the annual influenza vaccine. But I think that we've learned so much. We've proven so much to ourselves in terms of how we can respond, and it will only be it will only get better from here.
I like that. It's an encouraging note to end our conversation on. Thank you so much. I've learned a lot about the prep for this, and obviously just now chatting. But with that, turn it over to Sasha, who's going to run the Q&A for us.
Thanks, Katie.
Thanks, Katie. Dr. Pham, thank you so much for dropping all this knowledge on us. We appreciate you so much. And I have learned a lot from talking to you. And there are some really great questions, one in particular that I know you're going to have things to say on because we talked about it in our prep session. And so one of our audience member, Brett, has a question. And he's asking about your thoughts on pausing the J&J vaccine and the impact on health equity, especially given a one-shot vaccine has the potential to more easily get to those vulnerable populations that we talked about, and what the suggested next steps for our government, educators, and others can take to offset this negative impact.
Fred, I'm really glad that you asked that. I think that it is very, very controversial. I think hindsight will be 2020 in terms of whether or not the CDC should have put a pause on it. I think a couple of weeks ago, or actually during our conversation, Sasha, I felt that it was a mistake originally. I didn't think that 6 cases out of 7.5 million doses given was worth it to put something like this on hold, something that was honestly so successful. And I felt that it would really increase people's hesitancy and hurt the effort, the global effort overall. However, after doing some research into it, I think I've kind of backed off that wall a little bit. And let me explain a little bit why. I was wondering why there is such different treatment between the anaphylaxis that was published with the Moderna doses, how that was so different than these cases for the J&J. And now I understand better. So in the Moderna case, there were 10 cases of anaphylactic reactions. And they were all in folks that previously had a history of allergies. 5 of those people already had history of anaphylaxis. And I'm pretty sure all of them recovered. With the J&J, it's very important to recognize that this was a pause and not kind of a shutdown of the administration of the J&J. And they paused so that they could not only look more at these particular cases, but also put out guidance to providers on how to deal with them. And so overall, the risk of getting these types of clots with the vaccine are actually way lower than getting these types of clots in a lot of other things, in birth and deliveries, in actually having COVID in the general population, and so the risk is very, very low. But there was a pause so that we could take note and so that providers could learn how to deal with them, particularly not give heparin, which a lot of times in a thrombotic situation we do. But then, Europe has already restarted again. And so I think, our challenge here in the US is to get the correct messaging out. But, in doing the research, I think that, maybe, and this is hopeful, but maybe with this action, the CDC, which has lost a lot of people's trust in the past couple of years, maybe with this scrutiny, we'll gain some trust back. I'm hopeful.
Mm-hmm.
Yeah.
That's great. And, we did talk about, we talked earlier this week about, sometimes the decisions being political versus sensical. And I think that's where a lot of folks, including myself, get really confused and feel really unsure about next steps when decisions are made based on political will and not the facts. And so hopefully, with the CDC learning more and more every day, it'll be more factual and science-based versus political and, just trying to save face and trying to make the right decision to not get all that political flack in hindsight.
Yeah, I do think that it's good to recognize that there are so many factors affecting what healthcare policies are put in place. Even little things like we had talked about before, where we talked about the ages for these vaccines. So who's approved for these ages, and I did want to make the point to say that with these vaccines, the reason these ages are 18 or 16 is that that's how the research studies were done. Those were the ages that were approved in kind of the IRB in the beginning, right?
Mm-hmm.
But that doesn't it doesn't speak to how safe the vaccine is right now in this moment for ages 12 and above, ages 6 and above.
Right.
And so that's something good to recognize and to understand. I think these decisions will always be multifactorial, but
Mm-hmm.
I think that as these institutions separate kind of the knowledge and the dissemination of the knowledge from, maybe the decision making, at least we can trust that the knowledge coming out is real. And we also can understand how decisions have to take into account a lot of other factors.
Yeah, absolutely. Thank you. There is another question in the chat from Creighton, one of our Bay board members, and he asked, given that the United States has or will have a significant surplus in vaccines, what are your thoughts on sharing vaccine stockpiles with countries in need, engaging in vaccine diplomacy, acknowledging that the disease will remain a global threat with variants, mutations, and et cetera?
100%.
That's a long question, Creighton. Thanks.
Yes. Thank you for bringing that up. So there is a global and international organization or an international partnership called COVAX that is one of the signatories is the WHO, where these groups are getting together in the hopes that with collective bargaining power, they can purchase vaccines on behalf of or for lower and middle income countries. Interestingly, the US used to not be a part of that. but luckily, now that Biden's president, we are now a part of this effort.
Right.
It does not completely solve the inequity. And so the first part of your question, we actually are having a surplus now. Many communities have just unfilled appointments. There is, in San Francisco, we've tried to bring vaccine doses into the communities for folks to try to better serve them. Well, one of my friends was working at a community downtown, community center downtown, and they actually only had 3 people signed up in their entire day yesterday. And, and this is a community that really wants to be vaccinated. And so you can imagine there are many other communities where kind of there are a lot of doses being wasted. And so, I mean, I think it might be a great business or kind of nonprofit opportunity. Could there be a way logistically, right, to just collect these doses and have these countries, either pay a nominal amount or just pay for the shipping of these extra doses elsewhere? I don't know, but I think that there needs to be a better kind of matchup between the global need and the vaccine doses.
Right. And I think, and this is a question from me personally, just because I think with travel and folks being okay to travel when they have been vaccinated and going into countries that will not have access to vaccines until maybe the end of 2021, early 2022, and what that means for global inequity and, potentially destabilizing health systems in other countries more, just by virtue of being an American. And I just would love to hear what you think about that. And what are the ways that we can be more thoughtful about our actions going forward, even if we are vaccinated?
Yeah, that's a really, really good point, and really kind of deeper thinking. So basically, we are, many of us are vaccinated, and but that didn't stop these variants from, developing. The UK variants, the South Africa variants, the 2 California variants, the Brazilian variant. Until we get herd immunity, we are offering the coronavirus opportunities to mutate, right? And so even if this effort is just kind of self-serving, we need to get vaccines out there. We need to get the world vaccinated to decrease the chance that more deadly coronavirus mutants will develop. Until the world is vaccinated, we are not safe.
Right.
Yeah.
That's a great answer. Be careful, folks. Last question from Jessica. She said, thanks so much for being with us. On a global level, inequity in distribution to third world countries seems inevitable given technology needs to store vaccines. So something that you talked about earlier about the different ways that they're stored and how that even in the United States contributes to inequity. How do other countries solve for that? And can the US be a partner in that? And is that part of the COVAX goal, is to not only distribute vaccines, but to figure out how to get them there and store them?
Absolutely. So the COVAX effort is absolutely thinking about logistics.
Okay, great.
I think it's going to be really, really hard, honestly, to get storage units and transportation units at -92 degrees.
Yeah.
Right. But 32 to 46 degrees, totally possible. Totally possible. We do that all the time. That's regular refrigeration.
Right.
And so, I think that how this is going to play out is that there won't be a lot of mRNA vaccine being distributed, but there certainly are a lot of kind of viral vector vaccines that are going to be available. And I think that offers us a very real probability to get the distribution out to the places that need them.
Awesome.
Yeah. And it'll be interesting to see how these nanoparticles work out. I'm not really sure how those are going to be distributed, but I'm interested to see how it plays out.
Yeah, I'm gonna have to rewatch the beginning of this talk where you talk about the nanoparticles and the mRNA. But it's good information, and we're so fortunate that you are here with us, sharing your knowledge with us. And fun fact, folks, Dr. Pham's email will be included in our follow-up email. So if you have a question that you didn't get to put in the chat, you can email her, which is a huge privilege. Thank you, Dr. Pham.
I'm more than happy to do it.
Awesome. Thanks so much. And we're going to move on to Rachel and one of our health educators, Sophie. Thank you, Dr. Pham. We appreciate you. All right, we're going to move on. Thanks, folks.
Thank you, Sasha. Thank you, Dr. Pham. Thank you, Katie. I also want to say, Sasha, in recognition of what you just said, as a double click, as I like to say, I will also have to go back because not only did I not catch all the things, but I was very impressed by them. It took me back to all of my biology tests that I failed. So this is my opportunity to redo it. So thank you for that. Community, thank you for joining us for this conversation. We have one more part of this program, and it's a special treat for you. Sophie Jeanette is with us, and she's one of our health educators. And part of the reason that we do this, our health educators, I want to be really clear, are not teaching students about vaccines. They're not talking about anything except sexual health, mental health, and substance use. And yet there's a common thread, as we've been talking about this entire time, in regard to health equity and the need to be focused on what's happening in the world, but also what's happening in our classrooms and in our communities. And so Sophie is here to talk with us about, number one, what does her job as a health educator look like every day? Because that's important, that our health educators are how we do this work of forwarding health equity. But also we have a very particular conversation that we want to have with you about vaccine hesitancy and how that, hesitancy just in trusting the healthcare system, and how Sophie is thinking about her job as a health educator related to solving for some of that, if you will. So I want to introduce you to Sophie. I had the pleasure of talking with her on Monday. We had a really great conversation, and as always, this is an extension of our conversation. It's a continuation of that conversation. And I want to say too, I'm continually impressed by the way in which our volunteer health educators have really risen to the occasion in a moment that's been really difficult. Our program has historically been in person. Proximity is helpful a lot in building relationships and connecting. And we've watched our health educators not only rise to the occasion, but also take things a step forward in some ways and do things that they haven't been able to do in the past and really maximize opportunities in new ways. So we have so much appreciation for them. Sasha, this is going to show, the ways in which I rely on you to keep me focused where I'm supposed to be. I can't actually see Sophie. I trust that she's here. I saw her earlier. I see you now. Okay. Never fear. I see you, Sophie. Hi. Let me introduce you to Sophie. I'm going to ask Sophie a couple questions and then we'll close from there. Sophie is the co-coordinator of the PHE chapter at Berkeley and has loved seeing this community of health educators take pride in doing their work virtually in this era. She joined PHE 4 years ago and has grown attached to the mission of empowering young people, validating their identities and elevating their voices. She is a fourth-year student at UC Berkeley studying neurobiology and disability studies and plans to apply to medical school this year. Sophie, we're so happy to have you. Please wave for the people so they know who you are.
Thank you for the introduction, Rachel.
Thank you for being here. We appreciate you. And again, as we said, this is a continued conversation that began on Monday with Sophie. And I also want to say very quickly, I don't want to take up too much of the time, but part of this is also us challenging our idea of what it means to be an expert. We have Dr. Pham with us, who's an expert. That's such a treat. But also our health educators are experts. I could tell you all day about what it is that I know that they do, but much better to hear from Sophie because she does it on a regular basis. So that's why she's here with us today. Sophie, my first question for you, and again, continued conversation, how do you see the intersection between health equity and your work as a health educator? How does that show up for you?
Yeah, so as you mentioned before, our work as health educators is to provide these resources and skills so that our students can make decisions for substance use, mental health, alcohol, and other things. So a lot of times young people are not thought of as, really being capable of making these big decisions. Like sometimes it's thought of they need to be told what to do in terms of birth control, family planning, or other stuff. And so I think a big part of my role is addressing the inequity with young people and accessing healthcare. So giving them the confidence to do that. And then I think on top of that, race and class can add other layers that can make access to healthcare inequitable for young people.
Absolutely, absolutely. Next question for you. What's been beautiful about, doing this work of narrowing the gap relative to health equity in a virtual capacity, and what's been hard? Maybe you can give me one example of each. What's been great and what's been an opportunity, and what's one thing that's been challenging for you?
I think that one thing that's been challenging is engaging with young people in a Zoom type classroom environment. I think that in the past, something that was really important to us was building relationships with our students, which personally for me, going into the classroom and having that 5 minutes as students were arriving there for the day, it kind of opened some really nice conversations, and I could follow up with them in future weeks about what they told me was going on with their life. And I think that made them comfortable asking me private questions outside of class, or maybe more personal advice related to their own circumstances. And I think sometimes in online environments, there's not as much of this individual attention. And so building relationships, which is so important to PHE, has been more difficult. I think something that is a challenge for our students might be engaging with the PHE content. We talk about sexual health and substance use, and it sort of varies a lot as what technology a student might have access to or what their living space is. So students might be sharing a computer with their whole family and might not want to see if they're searching where to buy condoms or how can I see a therapist? So those kind of things go into what we try to think about and how we're making our workshops accessible. And maybe students have their camera off and their mic off and they're not participating because they're worried about who's in the room with them and what they might hear. But we like to think that they are engaging with us nonetheless. And students in the chat make us feel pretty encouraged, and we know that they're there. So that's been nice. And then I think maybe the best part has been, as a community of health educators at Berkeley, sort of growing together through the challenge of teaching virtually, I think has made us all feel really resilient and wow, we're getting through this. And the little moments you have with students where they give a great response in the chat, people come back to meeting and they'll share, yeah, my student last week said this, and everyone is so stoked on it. And so our virtual meetings, I think, have even become a really nice space for connecting with each other.
I love that. I love that. And something I should have said before, I said it in your bio, but didn't explain it. Your role as co-coordinator is to be the leader of a volunteer chapter, to be a peer leader amongst peer leaders, which is really powerful. Also, should make sure we shout out Dara, who's here, who's your partner in crime in that work. So Dara, make sure you wave so that folks know who you are too. You're also famous. That's important. You talked about, this process of building community, both with students and the challenges of that, but also building community within your volunteer cohort. And I want to ask you a quick question because I see we're coming up on time. Sasha and I had the opportunity to attend a workshop group meeting that you all held, which was beautiful just to watch you get the work done, even though you can't be in physical space with each other. And we marveled so much at that. But also you all had a really serious conversation in one of the spaces that really spoke to me and really kind of touched me in a particular way. So community, the conversation that was being had in the space was about the Tuskegee syphilis study. And if you're not familiar, a quick blurb that I can share with you. Essentially what happened in that circumstance is that the United States Public Health Service, in trying to learn more about syphilis, withheld adequate treatment from a group of 4 Black men who had the disease. And this is a clear example of systemic abuse that has often been cited in an era like COVID-19 around vaccine hesitancy, not trusting the healthcare system to keep you safe, to make sure that you are well, and to not be abusive in its interactions with you. Sophie, the question that I have for you is, why did you and Dara decide to have that conversation with the Berkeley chapter? What was the impetus for that? Go ahead, excuse me.
Yeah, so we decided to have this conversation during Black History Month, and we felt that it was really important given that a lot of the high schools that we serve have a majority Black or Latinx students or low-income students. We felt that it's really important to acknowledge race and to talk about injustices that have happened in an honest way, and to not shy away from them, even in conversations that are uncomfortable. We do have different workshops throughout the semester to train our volunteers sort of about power, privilege, and oppression, and how societal attitudes impact our work in the classroom, how our own attitudes impact our work, and then how we can address microaggressions in the classroom. But on top of that, it felt really important to us to situate ourselves within history and within the United States, and talking about things that happened, you know, in the not so like far past. Like this study ended in 1972, which my parents were like, you know, 15 or like very reasonable age. And so it just felt really important to us to talk about these things, and especially a specific instance where, like you mentioned, vaccine hesitancy. We talk about barriers that our students might have to accessing healthcare resources, financial barriers or transportation, but a big one is sort of mindset barriers, or if I go to a medical professional, will I be safe? Will I be respected? And these are very real concerns that our students have, that it's important for us to understand how serious they are and acknowledge them.
Absolutely, absolutely. Sophie, I want to thank you. It was such a joy to talk with you on Monday. It was such a joy to be able to continue the conversation with you in this moment. Thank you for the work that you do, but also for the wisdom that you bring. We appreciate you, and we look forward to future conversations with you. Community, something that I want to share with you as we close is from that same conversation. I'm looking over here at my other screen where I have this written down. To Sophie's final point, I heard when we were in these breakout rooms and having this conversation about this study, one of the things that one of Sophie, your colleagues, shared that I just thought was so profound is this recognition. So the quotation or the response from this other health educator was, this type of abuse is built into our current health system. This is not ancient history. And I wrote it down, and I've been thinking about it ever since. It's been a couple months since that point. But the reality is that this is not ancient history. This is now. And so in wrapping up, I want to make sure I thank Dr. Pham again for making sure to ground us in both what happened and also what is happening now and what we do next. I also want to make sure that I acknowledge again that this conversation is brought to you by Stanford Children's Health. We appreciate you all. We thank you so much for, again, endorsing the importance of these types of conversations. And then lastly, as we always do, one, we want to thank you, community, for being here. It's so valuable, as I said, to be able to learn alongside folks. We like to do our learning, but we like to do that with other folks so we can continue the conversation. 4 things that we'd like you to think about, 4 calls to action for us following this conversation. Number 1, if you heard something that really spoke to you, which we hope that you did, share it with someone, start a conversation and encourage them to do the same. Number 2, please continue to engage with us. We send out newsletters from time to time about other events and conversations that we're having, thoughts that we have about current events, what's happening within our classrooms, and we'd love to keep you abreast of those things, so please look out for those. Number 3, please consider, as you're able, contributing to our cause. $232 is the cost of providing Peer Health Exchange's virtual program to students at this time. And so if you're able, if you feel so inclined, please do contribute to the work that we're doing. That information will come out in our thank you email that will come out in a couple of days to you. And then lastly, please help us expand our community of support. We love, again, to be in community with folks and have these conversations. If you know anybody who you think we should talk to, anybody who can, who would be interested in engaging on these topics with us, please let them know about us, and please connect Sasha, please connect myself. We're so happy to have those conversations. Again, we appreciate this community. We appreciate you spending your time with us. Dr. Pham, we are so grateful to you. Sophie, we are so grateful to you. We appreciate you. Thank you, thank you. We will be here if you have questions about Peer Health Exchange. I'm not going to speak for anybody else this time, but if you have questions for me, I'm happy to stay. And again, thank you so much for joining us.